Good morning, everybody. My name is Nnamdi Ndobuka, and on behalf of myself and the co-chairs of the AP and Public Health Science track, Dennis Walker and Ibrahim Khan, I would like to welcome you all to this plenary session on epidemiology and public health science. It's my pleasure to introduce our speaker for this morning in the person of Dr. Stefan Baral, who is honored to present on the topic on challenging assumptions about the HIV pandemic in 2019. Stefan Baral is a physician, epidemiologist, and an associate professor in the Department of Epidemiology at the Johns Hopkins School of Public Health. Stefan completed his training at the University of Toronto in community medicine as a fellow of the Royal College of Physicians and Surgeons of Canada, and family medicine with the Canadian Council of Family Physicians, and provides clinical care through the Intercity Health Associates in Toronto. Through his role as the Director of Key Populations Program in the Center of Public Health and Human Rights, Stefan has focused on trying to understand why people continue to be at risk for acquiring and transmitting HIV, with a focus on the interactions of structural and network levels of determinants with individual level proximal risk of HIV infection. Together with colleagues, Stefan focuses on using all scientific tools available to characterize the distribution of HIV risk, including in countries with broadly generally HIV epidemics. Consequently, this work has included studying the burden of HIV and HIV-related vulnerabilities among gays, bisexual, and other men who have sex with men, transgender, women, people who use drugs, and sex workers in a range of HIV epidemic settings. In response to the disproportionate burden of HIV amongst population with specific vulnerabilities, Stefan has participated in advancing the standardization of methods and measures in HIV-related implementation research to study how best to implement programs serving marginalized communities. Please join me to welcome Dr. Stefan Baral to the stage.
Great. Those always look shorter on paper than they do when they're being read. So it is, I want to thank Dr. Khan, who's not able to be here this morning, for the invitation, and really the whole scientific committee. It's an honor and a pleasure. I lived in Saskatchewan for a year in high school. I haven't been back, so it is a pleasure to see really the changes in Saskatchewan over the last 25 years. So indeed, so just to start, I have no disclosures to report. So the talk is sort of split into four key themes. One is to give sort of a quick update on where we're at with the HIV pandemic in 2018. And I'll note that a lot of the data I'll talk about comes from outside of Canada. This is mostly an internationally focused talk, but I do think the implications relate to Canada, especially based on the talks that I've heard over the last few days. I'll then talk a little bit about I think what we see as a disconnect between the individual level benefits of treatment and the population level benefits associated with treatment. And I'll give some thoughts about what that may mean in terms of the delineating distributions of HIV risk, especially in the more generalized epidemic settings. And then finish really talking about how stigma remains a fundamental barrier to the pandemic response. So I'll say, I just want to start with sort of providing an overview, and I think it builds nicely on the talk that we heard last night. There's a lot of language. Some of you may have seen a lot of the language, especially in response to the Partners 2 study last week about the end of AIDS. And I think it's important to note that the HIV pandemic is growing, right? There are 37 million people living with HIV, and in a couple of years' time, there will be 40 million people living with HIV. So as much as we talk about the end of the pandemic, it is important to note that this is a pandemic that is growing. In addition, we have, it's hard to see the animations here, but I'll say that in addition, we had nearly 2 million people living with HIV. This is the UN AIDS estimate. Actually, the global burden of disease estimate modeling done out of University of Washington estimated that 2.5 million people acquired HIV in 2018. And so there is somewhere between 1.8 to 2.5 million people acquiring HIV, and on average there's been about a 2% annualized decrease over the last 5 years in HIV incidence. And so while there have been a lot of successes, and those should be heralded, it is not that we are actually looking towards the end of AIDS anytime soon. I'll also note that about 21 million people have accessed treatment, about 17.5 million have achieved viral suppression. So there's about 20 million people who remain living with HIV and who have not achieved viral suppression based on failures of programs. And I think as we heard last night, there has been this dramatic decrease in HIV incidence since the mid-90s, and I think that needs to be celebrated based on the work of communities of people living with HIV in addition to folks that are aiming to serve them. But there's also decrease in HIV-related mortality, also related to treatment. And so what that means is that about 800,000 people every year more are living with HIV and would need to access treatment. So while I just said that there's about 20 million people that are undertreated for their HIV, next year that'll be 21 million, and then 22 million, and 23 million. So that is not a static number in terms of the numbers of people still needing treatment. So I want to talk about these successes in terms of the population level, or I should say the individual level benefits associated with treatment. And I think we've already heard a lot of this at this conference, a very powerful session actually before the plenaries this morning. So the Partners Phase 1 study was really amongst the first studies to report in a clear observational approach using predominantly heterosexual couples that reporting condomless sex in serodifferent relationships, where a partner had undetectable viral load, that there was no transmission whatsoever. That was followed up by Opposites Attract, which was a study in Brazil and in Thailand and Australia, which predominantly focused on gay couples, or I should say was exclusively focused on gay couples. Also, in serodifferent relationships, reporting condomless sex, zero links transmissions in the context of over 17,000 condomless sex acts. And then finally, although these data were reported in Amsterdam, the paper came out last week, and I think resulted in a lot of media attention, was the Partners Phase 2 study, and that was follow-up focused on gay couples across Europe. Again, gay couples in serodifferent relationships with and reporting condomless sex act, and again, no transmission in the context of nearly 80,000 condomless sex acts. So I think it is clear that it is absolutely true that U equals U, and that there have been no documented cases of transmission from a partner living with HIV. There was additionally data before that, right? So famously, the HPTN 052 study was looking at incidence reductions and famously had a 96% reduction, and in effect, 100% reduction. But again, this was a randomized trial in the context of individualized serodifferent couples. Temprano and START were both studies looking at decreased morbidity and mortality associated with HIV, again, showing incredible benefits associated with mortality and morbidity associated with early treatment. So that set off a series of these three sort of mega studies that have all reported out now, and I think are important to reflect on. The first of them was a French-funded study, the ANRS 12249 study. This was a study that was done in the Africa Center in KwaZulu-Natal in northwestern South Africa. So they already had established HIV surveillance sites all over that region, and so it was very quick for them to randomize some clusters to universal treatment and others to a standard of care, which at first was a CD4 cutoff of 350, which then moved to 500. And I think, this is a predominantly rural setting, and one of the key things that they thought was the issue was just the distance to treatment. And so they put what they called task clinics basically up so that nobody living with HIV would be greater than 2 kilometers away from a treatment facility. And, initially, I'll just point out, there was really a lot of enthusiasm when early data were presented because they had high levels of initiation, over 90% in their treatment clusters as compared to their control clusters. But after about a year, it started looking problematic in the sense that treatment coverage was less than 50%, and it was very similar across arms. And so they finally reported out their cluster randomized control trials showing no incidence reductions associated with treatment in their study after a couple years of follow-up. So the next study that reported out, this was reported in Amsterdam, and it was the Project Search, and this was a study, a huge study also. This one was funded by predominantly the NIH, as well as some pharmaceutical companies. And the idea was that this would use a multi-disease, what they call patient-centered model. So it would address hypertension and diabetes and tuberculosis in addition to HIV as a way of drawing in men. Again, 2 sites in Uganda, 320,000 people across 32 communities. So just truly a massive study. And I want to highlight the successes of Project Search. So they were able to reduce the incidence of tuberculosis. They were able to decrease the mortality among people living with HIV, especially amongst those with lower CD4 counts. And they were also better able to manage hypertension among people living with HIV. They were also, in their intervention arms, able to achieve their treatment target, which is that 73%, or that 90, 81, 73 that is in effect reaching our treatment targets only in their intervention arms. But again, there was no incidence reductions associated with universal treatment in either arm. There was overall incidence reductions, but there was no difference between any of their arms in any of their sites. And then finally, pop art. So, I think pop art is an important study to talk about. It has not received the attention that it should, but it costs American taxpayers $250 million. And so I think it's worthy to at least talk about this study. This was a huge study that was done in South Africa and Zambia and reported out about a month ago, officially at CROI, but also did a webinar around it. It included about 600,000 people across these 2 countries in 3 arms. So arm C was the standard of care arm. Arm B was a prevention-only arm, like focusing on male circumcision and increased testing. And then arm A would be the prevention and the treatment arm, so universal treatment irrespective of CD4 count. And this just reported out that, again, there was no incidence reductions in their treatment arm, but there was in their prevention-only arm. So I think just to highlight, in the prevention-only arm, there was incidence reductions of about 30%. In their treatment plus prevention arm, there was no incidence reductions compared to a standard of care. So I think the community is sort of wondering what all of this means, right? And the investigators will often note challenges of in and out migration, of late diagnoses, of suboptimal retention. But one thing that holds true across these mega studies is this idea that these were interventions focused on the general population. And the fact that these were happening in generalized epidemics. And there's really limited study of like the actual individual folks that they're trying to serve with these treatment programs. And I'll say that the treatment disconnect between treatment and incidence has also been seen in a number of other settings. So Botswana is a country in Southern Africa that is famous for a number of reasons. One, it's a middle-income country, and so it also has great health infrastructure relatively, and has managed to achieve the treatment target that has been laid out for it, where that more than 90% of the people living with HIV in the country have been able to access treatment. And you've seen this treatment go up over the last number of years pretty dramatically. But during that time, there's been no incidence reductions associated with that treatment. And I'll note that the prevention services have not scaled up in the same way that the treatment ones have. And I think while we often talk about Botswana as a generalized epidemic, there's actually great variability in the incidence of HIV across the country. And there is higher incidence in places with commercial zones and trucking areas and other places where people hang out, and lower incidence in other settings. And so while it is a generalized epidemic, we understand it to be full of folks with individual needs and individual characteristics. I'll say that this is also true in the United States. This is data from Patrick Sullivan and others looking at splitting up 38 different states and Washington, D.C. into quintiles of PrEP usage. But when you look at it, you can see that viral suppression rates are pretty similar across these quintiles, ranging from 50 to 60%. And there's actually been an increase in viral suppression over the last 5 years. I'll note that in the States, the CDC could only report data up until 2015, which is a sort of systematic problem. It's not that it's old, it's just that is the way that their systems work. But when you look at the data in the low PrEP uptake states, independent of treatment, actually incidence has been increasing slowly but significantly in those states. And if you look in high PrEP uptake states, again, independent of viral suppression, you've seen decreases in incidence. And so you see this, again, a disconnect between viral suppression and new infections. And I'll note that their paper, in addition to one that followed up from this, was that the lower PrEP uptake among younger gay men is actually resulting in higher concentration of these epidemics among younger gay men, which again is a fundamental challenge to actually trying to achieve epidemic control. This is not just true in the United States. These are data from Valerie Delpech and others in the United Kingdom, a place, again, where I should say this may not look so similar after Brexit, but for now it is the United Kingdom that includes a series of different places. And you've seen, even in the context of high treatment uptake, actually slow but steady increases in infections across settings, and then you can see this massive decline only in London, really in the last year and a half, 2 years, since they've started implementing PrEP. So again, reinforcing that even in the context of high treatment uptake, they have not seen decreases in new infections. So I'm going to move on from talking about sort of that disconnect to starting to think a little bit about heterogeneity. So HIV among adolescent girls, we often talk about the needs of adolescent girls and young women in Southern Africa as being as obviously being disproportionately affected by HIV. And I'll just highlight that it is extreme. These are the most recent data available from South Africa. As of 2017, about 40,000 15 to 19-year-olds acquired HIV, and about, I think it's about 35,000 20 to 24-year-olds. And that's obviously far higher than in blue. You can see those among younger men who acquire HIV later. And so overall, in red here, you can see about a 5 times incidence rate among adolescent girls and young women as compared to younger men, and then it averages out for those above the age of 25. But I think as we try to understand why these transmission events are happening, it's also important to note that there is no evidence that there are any differences in terms of why young people choose to have sex around the world, right? That young people choose to have sex for procreation and for pleasure and need. And I think the differences are that needs differ pretty significantly. Access to education and appropriate commodities differ pretty significantly. And finally, the prevalence within sexual networks is dramatically different. It's dramatically different. When you look at the determinants, when you look at the determinants of HIV among adolescent girls and young women, you'll see that the sort of characteristics of alcohol and drug use, levels of condom use, untreated STIs, network-level determinants like age-disparate relationships, knowing somebody's HIV status that you're having sex with, and reporting multiple partners, and of course, as we heard a lot about last night, a significant amount of structural violence and challenges in condom negotiation. But if you look at a whole series of other studies, these are also the very same determinants that are risk factors among young women reporting transactional sex. And when you've looked at, although it is challenging to ask the questions around young women reporting transactional sex, across the board in Southern Eastern Africa, young women reporting transactional sex are disproportionately affected by HIV. And the overall odds ratio is about 2 times. So while adolescent girls and young women are disproportionately affected, some are affected more than others. In Tanzania, together with JAPIGO, a group has had the opportunity to explore this in more detail. And they're both a DREAMS partner, which is a large USAID-funded program focused on addressing the needs of adolescent girls and young women, in addition to being a treatment partner. So they've had the opportunity to explore in really large sample sizes some of these determinants. And so they sampled about 100,000 young women, and about 20,000 of them reported transactional sex. And so significant sample sizes to be able to explore some of these determinants. And I'll just note, they had data, HIV testing data on about 1,500 adolescent girls and young women. And you can see that there are higher burdens, again, among those young women who report transactional sex. There are also higher burdens among those folks, those young women who report older partners. And I'll also note that it's almost exactly the same people. That it is the same people reporting transactional sex that are also reporting age-disparate relationships, which I think provides insight into choices that people are making in terms of having sex. And this isn't just related to prevalence, right? So there's also incidence data where they show the same thing, that there are higher burdens of higher incidence rates among adolescent girls and women reporting transactional sex as compared to those who don't. These are pretty recently analyzed data looking at sex work across Southern and Western Africa, and it's a bit of a busy slide, but I'll just note the black line on top is the prevalence among sex workers in Southern Africa, and in gray is in West and Central Africa. And you can see that in South Africa, in countries across Southern Africa, the prevalence among sex workers is already about 40% among those 16 to 19, i.e. 4 in 10 are living with HIV, and it goes up to about 8 in 10 by the time they're 30 years old. But I'll also just highlight, and it's hard for me to see here, but I'm hoping you have a better view, is that treatment coverage amongst those younger women is about 20%. And so you have 80% of young women reporting transactional sex who have no access to treatment. And so as we're scaling up treatment, we're sort of seeing the disconnects, and we do a little bit better, but even at the higher levels, it's about half of the women have their treatment needs being effectively met by these programs. Kate Shannon and others reviewed this systematically in a paper published in The Lancet, which was an update last year. And across the board in Southern Eastern Africa, the best estimate is that about 1 in 3 sex workers is living with HIV. So that brings to sort of fundamental challenges. Why don't programs focus on the needs of sex workers as part of their fundamental programs? And that brought me to sort of understand more of some of my colleagues in the room, Sharmistha Mishra and others' work, about understanding what models were being used to tell us who and why people are at risk for HIV. And so the first model, and really the main model used, is the modes of transmission model. And this is the data related to sex work. So all that I've just told you about the needs of sex workers, the best estimates were that this model would say that in these epidemics, between 1 and 6% were related to the needs of sex work. And in that setting, a lot of governments will say, we just don't have the energy or the bandwidth to address what we consider to be a small issue as compared to the broader issue, which is the general population. And so I think it was important to sort of explore that. And so Sharmistha did great work as part of her PhD thesis at Imperial, really looking at these models. And there's sort of 2 key things that are happening with these models. This is the actual structure of the mathematical model. And I will note, I'm not a modeler, but you can understand that this oversimplifies the way that we are as a society in terms of how people have sex and in terms of why there might be both sort of acquisition and transmission risks. Basically, men and women are grouped into 6 different categories as it relates to HIV risks, and women can only infect men, and that is sort of the modality of the transmission. There's really nothing that speaks to this complexity of human sexuality. And then I'll also say that it is static in nature, which is to say that it only looks at your acquisition risk, but it doesn't include anything about your differential transmission risk. They updated that model to do what's called now the complex modes of transmission model, but again, it's still static. And I'll talk a little bit soon about why that's important. And Sharmistha's real innovation here is developing a model that also includes onward transmission and allows us to better understand the actual dynamics of transmission. So how does that play out? Here we've sort of modeled out infections related to serodifferent relationships. So this could be a wife acquiring HIV from her husband, and on the other side, you might have a sex worker acquiring HIV from a male client. Now, over a 1-year time horizon, of course, there are more serodifferent relationships, and it would look to be more relevant. I'll also note that even in the context of these, it's still important to understand why the first person was at risk for HIV. But even leaving that aside, you can see that it would seem more relevant. But in the context of stable partnerships where we've better addressed the needs and minimized the risk for vertical transmission, there's not a lot of risk of onward transmission. That's very different than sex workers and clients who don't have their treatment needs met at all, where there's a significant risk of onward transmission. So when you look at this over a longer time horizon, including a 5 and 10-year time horizon, you start seeing a very different picture in terms of why people are at risk for HIV. And this also plays out quantitatively. So these are data from Southern Africa using data from Eswatini, Lesotho, and South Africa. And over a 1-year time horizon, you can see that the data sort of match that of the modes of transmission model, which is that about 8% of the wider epidemic is related to the unmet treatment needs among sex workers and their clients. But again, when you take a longer term view of it, you start seeing that over 5, 10, and 20 years, actually the unmet treatment needs among the few is fundamental to the overall dynamics in these settings. This also plays out in terms of who is left behind. We often hear 90, 90, 90, 95, 95, 95, again, with no attention to who is in that, just these overall figures that we need to meet. And here, Jesse Knight, a graduate student in Sharmista's lab, had the opportunity to explore what would happen in East Swatini, which was formerly called Swaziland, also a country in Southern Africa, between South Africa and Mozambique. What would happen if you left the status quo, which is that you achieved 90, 90, 90, which they've done among all people, but you don't effectively meet the treatment needs among sex workers? And then what happens if you just better address the needs of sex workers? And what you can see is that in the context of the existing element, you see what we see now, which is the status quo, a slow and leveling off of new infections in the country. And it's really when you address the treatment needs of few that you see these significant benefits associated with that. And I think that's significant. There's also heterogeneity in terms of PrEP implementation. I will say right now, PrEP implementation in Kenya and South Africa is very demographically based, which is to say that if you're a 15 to 24 young woman, you can access PrEP. And there's no attention to the specific needs of folks, and in some ways might be reinforcing disparities. But they've also, Mike Pickles and Sharmista have also modeled this. What happens if you don't pay attention to the folks that you are providing PrEP to? And here you can see that if you just provide PrEP, you have 10% of folks accessing PrEP. If you just give it out randomly to folks that are 15 to 24, you will achieve some benefit, but it's not cost effective. If you do a little bit of targeting in terms of trying to address the needs and specify who it is that you're giving PrEP to, you do much better. And then obviously you do the best when you're most specific in terms of your approach, that the right folks are getting PrEP. And this is even independent of the fact that people understand their own risks and will stop taking PrEP if they know they're not at risk for HIV anyways. So I'm just going to move on to the needs of gay men, and I'm going to make a few key points that I think are important. This is a review that we've been updating over the last number of years, looking at the burden of HIV among gay men around the world. And I just want to say one key message is that there's a real consistency in how gay men are affected by HIV around the world, which is to say that about 15 to 18% of gay men are living with HIV, whether this be in North America, South America, Sub-Saharan Africa, South and Southeast Asia. There are some areas that are higher, including in the Caribbean. There are a number of places where it is lower, including Europe. But there's a real consistency of the epidemic. And I think that is because there's also no evidence that there are any regional differences in sexual orientation and gender identity. There are clearly differences in terms of the nomenclature that we use, outward sexual and gender expression. There are clearly differences in terms of social acceptance and punitive and protective laws that either protect or put folks in harm's way. Also, when we look at the needs of gay men across Sub-Saharan Africa, this is a review that is in process, also being led by Sharmista and others, where you can see that 90-90-90 is not being met for gay men across Sub-Saharan Africa. The best estimates are that a quarter of folks know that they're living with HIV, and about 8% have achieved viral suppression. But again, in a lot of the settings in which I work, this is the modes of transmission model that I just talked about. They will again say that gay men's needs are an issue for North America and Europe, and that this is not relevant across Sub-Saharan Africa, and they can rely on traditional modes of transmission studies to reinforce that message. This is looking at the modes of transmission studies that were done across Sub-Saharan Africa. Basically, the highest estimate was from Kenya, where the best data were available at the time, and it said about 15% of the overall epidemic was related to the unmet treatment needs among gay men and other MSM. So again, in that setting, it's easy for them to just say, we just can't focus on it. We don't have the bandwidth as a program. So we've had the opportunity together with colleagues at Bristol and Imperial to more empirically assess this, to develop a mathematical model actually using empiric data collected here in Senegal, which is a country in West Africa, where we had data from sex workers and their clients, from young and older gay men. We had trans women also included, and then a very traditional model. And I'll just say, when you do that, it's a fundamentally different outcome. Here what we can see are basically these 10-year population attributable fractions from 1995 to 2005 to 2005 to 2015, and then the last one, 2015 to 2025. And in blue, what you can see are basically the estimates related to the unmet treatment needs among gay men. And if you include that as well with the unmet treatment needs that are related to infections for their female partners, it's basically most of the epidemic. It's about 80% of the overall epidemic, and it's actually concentrating amongst gay men. And I think that's also something that we've seen, that when we address the needs of sort of many, we really don't effectively address the needs of the few, and these epidemics tend to concentrate. We've also had here phylogenetic data. So Senegal is a place where there's great laboratory infrastructure, and they've been sequencing HIV for many years. And so under the leadership of Eric Voltz, also at Imperial College, he's been able to use the phylogenetic sequences that existed that were noted as general population sequences, in addition to the ones that were purposely collected specifically from gay men and sex workers and others. Here, these are data from MSM. And you can see that their median PAF estimate is about 50% also. So it's just a place where the phylogenetic data really reinforce the epidemiologic data, and also reinforce what one sees in Senegal, which is that mostly it is men acquiring HIV. I won't get into it, but I'll say that Cameroon is a country in Central Africa with very similar dynamics, although a little bit more generalized. But again, when we pay attention over longer periods using empiric data, we see that the unmet needs of sex workers, of gay men, are fundamental to transmission in the country. So, heterogeneity doesn't just end in terms of understanding the needs of gay men. Over the last 8 years, we've had the opportunity to ask folks about their gender identity. So initially, we made the same mistakes as many. More recently, we've done better, and we have about 5,000 participants that were enrolled predominantly for MSM studies, but had their gender identity assessed, and from 8 countries across Sub-Saharan Africa. And about a fifth, about 20%, identified as transgender women, and in adjusted analyses were far more likely to be living with HIV than cisgender MSM. I will also note had fundamentally different experiences in terms of physical violence, enacted, perceived stigmas as trans women as compared to their cisgender MSM friends and colleagues that are in the same countries. And also we've seen much higher burdens of mental health among trans women as compared to cis MSM. And so, to sort of think about why that is, Aidan Scheim has led a series of these analyses with data specifically from Côte d'Ivoire. Côte d'Ivoire, also a country in West Africa. And so this was a place where about 1,300 folks were enrolled into this study, and about a quarter of whom, again, identified as trans women. Overall, there was a 72% increase in depression among trans women as compared to cisgender MSM. And so Aidan had the opportunity to do both sort of, if you look at it at face value, it may reinforce stigmas that trans women are burdened by depression as compared to cis folks. But here, because of the availability of the stigma data, he was able to adjust for the increased burdens of stigma affecting trans women as compared to cis MSM. And when you do that, actually the mediated effect goes down to about 25%, and it's no longer statistically significantly different. And so again, it just reinforces this role that stigma has in potentiating HIV risk, but also other adverse health outcomes. So then, why don't we know more about stigma? This was a systematic review that was done a couple years ago, published last year. And you can see that in this setting, there's actually very limited stigma data that have been collected for any population really across Sub-Saharan Africa. Any of the key populations, I should say. So this is not HIV-related stigma. This is not the HIV stigma index, of which there's more, but really stigma related to sexual orientation, sexual identity, et cetera. And I think it sort of underscores that in the absence of collected data, and I will also note that there's tons of prevalence data that have been collected, dozens and dozens of studies have been collected, just stigma data wasn't part of it. The only thing they asked folks was like condoms and sexual partners, et cetera. But I want to make a few points. One, I am talking a lot about Sub-Saharan Africa. We have a grant together with colleagues also at Emory University where they run what's called the Amos Study. Amos Study is the American Men's Internet Study, which is like the cousin of EMIS, which is the European Men's Internet Study, which I think also enrolls in Canada from what colleagues have told me. But I will say that here in green, you can look at the burdens of stigma among folks across the United States. In blue, it is folks from across West and Central Africa, and in yellow, it's folks from Southern Africa. And you actually see a remarkable consistency in the patterns of how stigma affects gay men around the world. I'll note that there was actually higher burdens of stigma among some folks in the United States, also partially mediated by increased disclosure and being more out in their lives. We've done a series of these exploratory factor analyses, and I'm always interested by the marked similarity in the constructs that you measure, whether gay men be across Sub-Saharan Africa or again in the United States, that perceived stigma from family and friends, anticipated healthcare stigma, and community discrimination experiences really hold true as being mediators of HIV risks across settings. And then to switch gears a little bit, often when we talk about stigma, also from this systematic review, there was over 500 studies looking at stigma affecting gay men and other MSM around the world. But what was striking also is that there was basically no studies of stigma affecting sex workers, including male and trans sex workers. And there was actually 0 studies looking at stigma among people who inject drugs. And when we look at stigma, this is work also done together with Kate Shannon and Carmen Logie and others. When we look at how stigma affects sex workers around the world, these are data now globally, and we know that there's incredible amounts of physical violence affecting sex workers around the world. And we had the opportunity to look at this in more detail across Sub-Saharan Africa, including about 7,000 sex workers. And I'll just note a few key things. One, a tremendous amount of physical and sexual violence, also high levels of harassment and high levels of anticipations of adverse events happening if they seek care. So I think as we're thinking about trying to encourage folks to seek treatment, given higher burdens of HIV, we have to understand their actual concerns and what may happen when they engage in that treatment. And in these settings, we've had the opportunity to look at sort of 3 different types of laws or law settings that exist, where either folks, it's fully criminalized, or it's sort of partially legalized, or I should say where there's no legal statute in place, or where it's actually partially legalized. And I'll just say that in that setting, there's about an 8 times odds ratio of sex workers living with HIV where it's fully criminalized as compared to where it's not. So I think as we heard in that talk last night, structural violence is pretty fundamental in driving HIV risks here, and this was far more important here than when we adjusted for like individual sexual practices, condom use, all of those things. The thing that holds out the most relevant are really the laws in place. So just kind of a few closing thoughts. One is, the pandemic goal, you can follow the curve along of incidence, and the pandemic goal of 2020 is that 500,000 new infections will happen. And I think that's predicated on, this is actually a cover, there may be another cover like this in the next couple of weeks, but this is from 2011 after 052. Sort of reinforcing that AIDS is something that is over. It is something that is forgotten about, but we're now like 230 days from 2020, so it's clear like this goal is not going to be met. It's also clear that the goal of ending AIDS by 2030 is not going to be met, and I think there's sort of a need of really stimulating what our responses need to look like. In that same context, the best case scenario for funding, this is looking at funding over the last 20 years, and obviously we've been in a kind of a state, I should say, just a flat funding level over the last 5 or 6 years, and best case scenario is that that's what will continue. So as we think about addressing the needs of so many more, we recognize that there are not going to be more resources to do it. So the last data point I'll share with you is from Mike Pickles and Sharmista and others about, well, what does it mean to have really efficient responses in the context of very limited resources? And I'll just focus on the data from Lesotho, again, because it's such a broadly generalized epidemic where folks talk more about the generalized epidemic and general populations than they would about the needs of any specific individuals. But here you can follow in black basically what's happening right now, which is, again, a very slow decrease in numbers of new infections. There's a lot of talk right now of taking away programs for key populations and really just putting them out there as treatment programs. And here, when they did that, that's that scenario in red where you basically see increases in incidence going back to what we would have seen a number of years ago. And in green, what it basically is saying is that the most efficient responses are the most specific responses. And so it highlights that while it may be challenging and complicated to mount specific responses in some of these settings, it's also fundamentally important to a sustainable response. So just a few key thoughts to finish with. There's no doubt that universal treatment for HIV is both efficacious and effective. It allows people to live normal lives, as we've heard about so powerfully this morning. But I think it's also important that we have reasonable expectations when we use language like TASP, or treatment as prevention, that we understand that there's actually no real data right now at the population level to support that treatment alone is really what is causing incidence reductions in the absence, obviously, of prevention services. I would also argue that the world is far more similar than it is different. My travels have only reinforced that, that everywhere is the same and people are the same. And there's also no fundamental differences in terms of why people have consensual sex. There's also no differences in terms of the diversity of sexual orientation and gender identity. And thus, the same folks tend to be at risk around the world, whether or not we're asking them those questions. So what does it mean to overcome and decrease HIV incidence? I think that we have to overcome our preconceived notions of, again, why folks are at risk for HIV based on geography. I think that depending on sort of like the 10-10-10 or the 10-19-27, however you define it, it matters more about who rather than how many folks whose needs you're not meeting. And I do think that there's value in thinking about how implementation research strategies can better address the needs of marginalized communities around the world, as they have done better across Canada and as we've heard in Saskatchewan. And so I'm here presenting these data. I will say that the folks that engage in these research studies do so with no personal benefit. The community groups work under intense pressure. People have been arrested, people have been killed, generating and just advocating for their community. And so I want to honor them and thank them. And these are some of the organizations that have contributed to this talk. So thank you.
I'd like to thank Stefan for his international tour and for the food for thought of how we in Canada are not leaving anyone behind. Thank you.